some different areas in the world. We are back. We are back after the great success of the United Conference of Hepatogastroenterology and Infectious Diseases 2020. And today we are back with one of the post-conference activities. Today we are celebrating the World AIDS Day. And as you know all, it comes under the slogan of global solidarity and shared responsibility. And regarding the slogan, we are really feeling proud. You know, UCHID is one of the earliest and the strongest calls for unifying the efforts of the all healthcare workers who are working in the field of hepatogastroenterology and infections to have a united voice and to help the patients and support them. So we are keeping on the field, keeping on the road. We are calling all our valued participants and attendees to keep following us, and we are promising you to provide you with the best discussion and best knowledge with our valued professors who are sharing today as speakers and chairpersons. I'd like to thank the steering committee of the UCHID for supporting this meeting. Thank all of our professors and speakers who are sharing us today. Also, I'd like to thank MSD for supporting the today's meeting, and I think also they shared with me some very good ideas and news about allowing the voluntary licensing and agreement for doravirine to be expanded to the resources limited countries and settings. And I think we can make a call for all the generic companies in Egypt and Africa and everywhere to start to make use of doravirine. I think it has a very good effect and use for the people living with HIV. Also, going with the paradigm shift in the prevention. You know, now we have a very good idea about the need for the long-acting injectables for the prevention and how they are making or they are working as a game changer in the prevention. So Merck also have announced that they have very good news from the phase 3 trial investigating the Stellarvir as a 1 monthly injection for PrEP. So we hope we will have a very good news about the long-acting injectables for PrEP very soon. Now, it's my pleasure to introduce the first panel of discussion with Professor Amjad Zahabi and Professor Hiba Abdullah. Dr. Hiba, the floor is yours to start the first panel discussion.
Good evening, everybody. Welcome to one of our scientific meetings through the activity of the UCHID conference. And today we are celebrating the World AIDS Day, as Dr. Kordi mentioned. Today's meeting is arranged by MSD, and I want to thank them for the continuous effort in the field of the HIV and AIDS. Today's meeting is running in two panels of discussion with two teams. I'm honored to be the moderator of the first team. I want to welcome Professor Dr. Amjad Zahabi as the chairperson of this panel of discussion, and I will welcome my speakers, inshallah, in the following lectures. Our agenda today will cover the item about the medical services provided to the people living with HIV. We are going to talk about the screening and testing, improving access to medical services for people living with HIV, the HIV and co-infections and the other comorbidities, and to minimize the possible drug-drug interactions that can occur in those patients. HIV infection is now considered as a chronic illness, and due to the availability of the antiretroviral therapy, people living with HIV are now aging and enjoying a good quality of life. The estimated number of people living with HIV in the MENA region was about 230,000 by 2015. Approximately the related deaths ranging approximately 38,000. Less than 12% of them were receiving their antiretroviral therapy. Egypt is considered a low prevalence country for HIV. The rate is about less than 0.03%, and males representing more than 80% of the infected patients, with the sexual contact representing more than 2/3 of the infection, source of infection, followed by the injection drug use and the vertical transmission. Now, people living with HIV are facing numerous problems. The improved antiretroviral access has prolonged the lives of people living with HIV, so it is increasingly now a chronic condition that can be effectively managed through safe behavior choices, strict adherence to treatment, and appropriate monitoring of HIV infection and other medical and social conditions. Also, as the treatment prolongs life, people living with HIV are faced with many conditions, same as the general public population experiences as we age, such as the heart disease and diabetes. Additionally, the comorbid conditions such as substance abuse and mental illnesses affect many people living with HIV across their lifespan and can be further exacerbated by social conditions such as poverty and lack of housing. Now, the HIV care continuum is a program or a model starting from the diagnosis of the patient with HIV, incorporating him in the medical care, receiving the antiretroviral therapy, and his maintenance in the medical care to achieve the viral suppression and to manage the possible comorbidities that can occur to this patient. This run through the what's called multidisciplinary work or multidisciplinary team, starting from obtaining the thorough clinical assessment for the patient, physical history, physical examination, attention to the specific immunization schedule and the specific laboratory evaluation. Clinicians should encourage the combination of antiretroviral, the start of the combined antiretroviral therapy as early as possible, assessing the patient readiness and ability to maintain the lifelong treatment, the management of possible side effects of the antiretroviral therapy, the management of possible co-infections like the hepatitis viruses co-infection with HIV, and to monitor the viral load and the CD4 count. And finally, the standard health care must maintain to prevent HIV and non-HIV related comorbidities and mortalities, specifically the opportunistic infections and the other non-AIDS defining conditions. Now, our panel discussion will start or will work through a possible case scenario. We have a 24-year-old patient with chronic HCV with compensated liver cirrhosis, and he's diagnosed with HIV co-infection, presenting with fever, weight loss, and generalized lymphadenopathy. And this is a case that we can meet in everyday practice. Now, applying the concept of HIV continuum of care, I will invite Professor Dr. Amjad Al-Zahabi, Professor of Hepatogastroenterology and Infectious Diseases in Azhar University. He is a member of the Egyptian Society of Fever and the steering committee of the UCHID conference. I want to ask him about the common association in Egypt between the co-infection of HIV and HCV. Is it a very common association or not? And I want to know the important clinical tips for such situation. I'm talking about the testing for HIV and other infections, the other baseline investigations that must be done to this patient, and the brief highlight about the HCV treatment in this patient. Please, Dr. Amjad.
Thank you very much, Professor Heba, for this introduction and the nice case you presented. And we'll discuss it in a practical manner, in fact, or in practical approach to a case. This case is an HCV patient with compensated liver cirrhosis, and he has fever and lymphadenopathy as well. So, and HIV was detected to be positive. This slide. As per the first question, that is this combination or association of HCV and HIV is common in Egypt. I say that because HIV and HCV co-infection are sharing the same route of infection, either hematogenous through drug injection, or vertical transmission, or unprotected sexual intercourse. This means both viruses are sharing the same route of infection. So there is common association between HCV and HIV. As per the literature, it is said that in the United States, the HCV patients among HIV patients ratio is about 25 to 30%. As per the WHO in Europe, they stated that maybe 40% of cases of HIV are also co-infected with HCV. Preliminary statistics from Egypt stated that 25% of HIV patients are also having HCV co-infection. So the question is, yes, it is a common association between HIV and HCV among Egyptian patients, which is approaching to 25% of HIV patients are also having associated HCV. According to the second question, is this co-infection is harmful for the liver more than mono-infection? In the other way, does HCV-HIV co-infection hurt the liver more than HCV infection alone? You know, from the natural history of HCV infection, the patient remains in a state of chronic hepatitis C for years until he got liver cirrhosis, which may range to up to 20 years, 15 years, 20 years until he reached the liver cirrhosis. But if the patient has co-infection, the progression to fibrosis is more fast, and it is more than 6 times higher than the mono-infection. And the risk of developing cirrhosis and HCC as well is more if the patient is co-infected with HCV, HIV co-infection. It is said that this process may take 5 years or 7 years until the patient has decompensated cirrhosis when he is double infected or co-infected of both viruses. While in mono viral infection of HCV, it may reach up to 20 years until he got cirrhosis. So the association of both viruses are having accelerated process of fibrosis and cirrhosis and the complications of cirrhosis as well. So there is some impacts of the HIV virus on hepatitis C patients and impact of HCV on the patients of HIV. It is said most probably due to this is due to impaired immune response because the HIV virus usually attacks the CD4 cells, and of course it will attack and it will attenuate the immune system, and the patient is more liable for developing cirrhosis and fibrosis rapidly. So we have to test every patient with hepatitis C or B for HIV, or we have to also investigate any patients with HIV should be screened for hepatitis B and hepatitis C as well. The patient should be screened also for TB, because you know there's a strong relationship between the TB patients and HIV. So every patient with TB should be screened for HIV as well. If we start for testing the patients for detection of the HIV, we usually depend on 2 ELISA tests. We have what's called the rapid test, which if it is positive, we should go for another confirmatory test. So if the patient has two positive tests, then we consider the patient as HIV patient. Especially if we used the ELISA, which is called the fourth generation ELISA test, which searches or detect the antigen and antibody as well. This is a good test, in fact, and is used for early detection of cases of HIV before the other ELISA tests are becoming positive. So we have to screen most of the patients, all the patients of HCV and HBV for HIV. The clinical importance of that also, that if we decided to treat the patient with HCV, with DAS, direct acting antiviral drugs for HCV, these drugs might lead to interaction with the HIV antiretroviral drugs. So we should know that if the patient is having both co-infections, to avoid the drug-drug interaction between the HIV DAS and the antiretroviral drugs. So it is very important to screen all the patients of HIV for HCV and HBV as well. So what are the risk groups who should be investigated and should be screened for HIV? As I said, any pregnant female should be screened for HIV. Just to avoid the vertical transmission from the infected mother to her baby. All patients with intravenous drug users should be screened for HIV. All hemodialysis patients or patients who are on repeated blood transfusion due to any inherited or hereditary blood disease and the likely hemophilia or other diseases which need repeated blood transfusion, we should screen them for HIV and hepatitis viruses as well. If we are confronted with a patient with both infections, this will raise the question, which to start with, DAS or ART? And the final and the opinion, which I prefer, in fact, we look for the CD4 count of the patient. If it is more than 500 cells per cubic millimeter, this means this patient immune system is still viable and still, in a good condition. So we have to start the anti-HCV drugs for 3 months or 6 months maximal, according to the condition of the patient, and just to avoid the interaction between the antiretrovirals and the DAS drugs. So if we are confronted with a patient with HCV and HIV, we should look for the CD4 count. If it is more than 500 cells per cubic millimeter, we should start with the DAS and finish it. And once the patient is SVR, sustained virological response, we start to give him the antiretroviral drugs for HIV. But if the patient has CD4 count less than 200 cells, this means his condition is threatened and he is in a bad condition. We should start immediately the antiretroviral drugs until his immune system regains its viability and his condition improved. Then we introduce the DAS drugs. So we should consider that most of the antiretroviral drugs could affect the liver and could have an hepatotoxicity with different degrees. But like nevirapine, stavudine, and tipranavir, in particular, have been associated with development of hepatotoxicity more than other antiretroviral drugs. And also, it is stated that the ART, the hepatotoxicity following ART inhibition is more common in HIV and HCV co-infected patients with high risk of those patients with more advanced liver diseases. There is some precautions or some, considerations while we are treating the patient with HCV and while he is on antiretroviral drugs. If antiretroviral is an enzyme inducer like efavirenz, we should increase the dose of efavirenz from the ordinary 60 milligrams per day. We should increase it until 90 milligram daily. But if the ART is an enzyme inhibitor like ritonavir and copicistat posted atazanavir or darunavir or elvitagravir, we should reduce the dose of the efavirenz to 30 milligram daily. Okay. As per the recommendations of the Liverpool and the also recommendations of the National Committee of Fighting Virus C or hepatitis viruses, they said that we shouldn't give any protease inhibitors with inhibitors for HIV. We shouldn't give it if we are treating the patient with sofosbuvir. Ribavirin should not be used with didanosine or stavudine or zidovudine. There's some interaction here, and some drugs are decreasing the dose of the concentration of the sofosbuvir especially, so its effect for fighting the virus C will be decreased. I think that's all about the co-infection of HCV and HIV, unless there is some questions or comments from my colleagues or from the audience. Thank you.
Thank you, Dr. Amgad, for this focused and concise presentation. I will just have comments about the services for people living with HIV.
Yes.
I want to share screen, please. Dr. Amgad, I'm going just to focus on some challenges facing people living with HIV regarding their access to their medical care. I have found in the literature 2 Egyptian studies covering the barriers to medication adherence for people living with HIV. And the summary of those 2 studies cover some items that may be an obstacle or challenges facing people living with HIV to access their medical service. Now, what about the baseline evaluation Dr. Amgad talked about clinically and the relevant investigations? Are these done or not? Sometimes due to the high burden on the medical staff, these baseline evaluations are not done well. The counseling before starting the treatment and the readiness to maintain the treatment, the initiation of the antiretroviral drugs, the available drugs and the stock outs that can occur to these drugs. The process of distribution of the antiretroviral therapy, it is centralized, it is distributed in certain centers, they may be far away from the patient. This may present a problem to these patients to access their medical services. After receiving the medication, the drug monitoring and follow-up, as well as the problems associated with the drug intake, if there are side effects or drug-drug interactions, and to monitor the effect of the drugs on the CD count and the viral load. And the big issue about the HIV stigma, which occur due to lack of knowledge of the infection control measures. Some doctors or some medical staff may have fears of getting infected with HIV. There are some disbeliefs regarding the effectiveness of the infection control measures in the medical staff and the possibility of the occupational exposure to infection with HIV. The misconceptions regarding the medical care for people living with HIV and the bad beliefs about they do not deserve care, or they are dirty, or they are dangerous to the community. They want to infect us. All these judgmental issues and the negative connotation make a big challenge in front of those patients to access their medical service. Of the barriers also, the excessive burden on the healthcare workers. The counseling is usually directed to the medical rather than the social history. And usually there is no time or field for the patient to ask the healthcare workers freely personal questions. Now, we need a comprehensive multidisciplinary approach is needed for the HIV/AIDS services due to its complexity, and it must be implicated in the health of individuals with HIV/AIDS to improve the access to their medical services. There is a model or a framework called the Program Collaboration and Service Integration. It is a framework for organizing and blending interrelated health issues and activities, as well as the prevention strategies to facilitate more comprehensive delivery of the service. It is formed of program collaboration and service integration. Program collaboration is a relationship between two or more entities, mutually beneficial, and involves sharing resources, common goals, and responsibilities toward these patients. The service integration is a mechanism of service delivery, aims to provide services from multiple programs that appear seamless to clients due to reduced administrative barriers. Three key issues are identified to ensure that people living with HIV receive their optimal care and support services, composed of the holistic approach to treating people living with HIV, partnering to leverage resources and increasing efficiencies in service delivery. This can be summarized to an example that separate programs dealing with HIV, sexually transmitted diseases, or TB that run by separate administrators may be collaborated in a communicable disease prevention services branch. This will lead to providing comprehensive prevention care and treatment services within and across the various clinics. This will lead to a reduction of the redundancy and the challenges navigating services. The leveraging resources through program collaboration, it means the establishment of numerous formal relationships with a variety of services providers, including the community-based organizations, qualified health centers, correctional facilities, and substance abuse and mental health care facilities to provide screening and treatment services in the community. Finally, creating efficiencies through service integration. It means that people living with HIV can be treated in either clinics for HIV, sexually transmitted disease, and TB, and they can start treatment at the same day of diagnosis. This will minimize duplication of services and increase efficiencies in service delivery. Other solutions may include increased number of facilities providing relevant investigations, increased number of drug refill points, and to put the geographical distribution of any country in consideration during the management and distribution of the medical services for people living with HIV. Now, after we heard from Dr. Amjad about the investigations must be done to the patient of diagnosis of HIV, we heard about the baseline CD count and the viral load. Back to our case scenario, we have our patient with a baseline CD count of 55 cells per cubic millimeter and the HIV RNA of 54,000. And I will invite Dr. Hamdi Ibrahim. He is an internal medicine consultant and the head of ICU at the National Hepatology and Tropical Medicine Research Institute, to ask him about this finding in this patient. It is a common finding today to have a patient with this CD count. And what are the possible events that can happen to this patient with this CD count? How to prevent and manage these possible events in this patient?
Yes. Bismillah ar-Rahman ar-Rahim. First of all, I wish to express my deepest gratitude and appreciation to my dear professors and colleagues, Professor Dr. Amgad Zahbi, Dr. Shakron, Dr. Ahmed Kurdi, Dr. Heba, Dr. Dua, and all other colleagues for this kind of invitation. Yes, this question is very important, CD4 count, and the relation between CD4 count and the other opportunistic infections. There is a strong relation between CD4, the number of CD4 count, and appearance of opportunistic infections. At very low CD4 count, we can find the cytomegalovirus infection below 100. And also, this occurs with disseminated cytomegalovirus infection like CMV colitis, CMV retinitis that can cause blindness. And also, atypical mycobacterial infection. This can appear at CD4 count 15. Also, extra pulmonary tuberculosis can appear at very low level of CD4 count. Opportunistic infection, now I will start to discuss the common opportunistic infections, and I will السلايدز مش بتجيب معايا. First, describe or define what is opportunistic infection. Opportunistic infection, an infection by a microorganism that normally does not cause disease, but becomes pathogenic when the body's immune system is impaired and unable to fight off infection, like AIDS, neutropenia, congenital or iatrogenic host defense defects. Opportunistic infection can adversely affect the natural history of HIV infection by causing reversible increase in circulating viral load that could accelerate HIV progression and increase transmission of HIV. CDC definition of an HIV positive person as having AIDS if the patient has had at least one of over 21 AIDS-defining opportunistic infections, and or if CD4 count less than 200 or less. Are opportunistic infections are common in people with HIV? Before HIV medicines to appear, the main cause of death in HIV-infected patients was the opportunistic infection. After HIV medicines reduce the risk of opportunistic infections by preventing HIV from damaging the immune system. Are opportunistic if the patient, why some patients are taking antiretroviral therapy and opportunistic infections can appear on them? Yes, we know about 20% of people who have HIV do not know that they have HIV. So the first presentation of them may be the HIV opportunistic infection. The first presentation of their HIV may be the opportunistic infection. Also, some people that know that they have HIV infection aren't getting treatment with HIV medicines or are not adherent to treatment with HIV, so they are liable to get opportunistic infection. Some people may be taking HIV medicines, but the medicines are not controlling their HIV or there is some sort of resistance to HIV medicines. Nearly every patient with HIV has some cutaneous manifestation during the course of the disease. And the dermatologic manifestation may be a clue to diagnosis of HIV infection. Like seborrheic dermatitis. Seborrheic dermatitis can be a normal finding in babies and in some people, but if it can appear in HIV persons, it is generalized greasy scaling with excessive dandruff on scalp and face, and may be recurrent infections. Also, if people have already psoriatic lesions, psoriasis, there may be exacerbation of the existing lesion or appearance of new psoriatic lesions. This dermatology may be dermatologic or psoriasis of the nails or ulcerative manifestations of psoriasis. This patient was near psoriasis with psoriatic arthritis in a patient, with AIDS. Also, herpes zoster infection can appear if you can suspect in a young patient. Commonly, herpes zoster infection appear in elderly patients above 50 years, diabetic patients. But if we see recurrent herpes zoster infection in a younger patient, and this commonly appear in atypical manifestations like multiple dermatomal distribution, multiple dermatomal lesions of herpes zoster, or maybe the infection crossing the middle line, you should suspect of HIV infection. Even also, if you find two combined lesions, two combined skin lesions in the same patient, like massive oral moniliasis and psoriasis, or any other two cutaneous lesions, you can suspect HIV. Also, some cutaneous lesions are so pathognomonic to HIV infection, like oral hairy leukoplakia. This is like a candidal lesion, but it is adherent and appears on the side of the tongue in HIV patient. This is epidemiologically linked to Epstein-Barr virus infection. Also, in rare conditions, angiovascular tumors may appear like bacillary angiomatosis. This is in HIV patient. It's not so common. I saw it only one case. Bacillary angiomatosis is caused by gram-negative bacilli, Bartonella henseli or Bartonella quintana. Also, Kaposi sarcoma. The photos in below. Kaposi sarcoma, which is yellowish brown nodular lesions, and appear or maybe appear on the palate, may appear on the trunk, may appear on the extremities. This is angiovascular tumors, may be disseminating or maybe single lesions. This is also oral hairy leukoplakia. Next, this is bacillary angiomatosis. Also, infection, bacillary angiomatosis. This patient, the only patient I saw in with AIDS. You see multiple globular nodular lesions disseminating on his face and extremities. Scabies common appear in prisoners and in camps in HIV patients. This is very dangerous in those patients because it can cause sepsis and septic complications, and the patient may die with septic shock from if not treated early. Also, molluscum contagiosum. Molluscum contagiosum may be find a normal finding in young children. This is caused by a poxvirus. Molluscum contagiosum in HIV patients is giant lesions, nodular and papular lesions appear in the face and on the buttocks or the genitalia. Also, you can find massive oral moniliasis in the face. Massive oral mononucleosis is a dominant sign we can see in HIV patient as a sign of opportunistic infection. It may be a membranous lesion, and it may be localized or disseminated. In severe cases, disseminated candidiasis can disseminate to GIT and esophagus, and this can be seen by endoscopy. Next, same esophageal candidiasis. Next, cytomegalovirus infection can be disseminated and cause colitis, severe pneumonia, pneumonitis, or even blindness, CMV retinitis. This is a common finding, and if an HIV patient suffers from blindness, the cause most probably will be CMV retinitis. This is the arcuate lesion in cytomegalovirus infection that occurs in CD4 count less than 50, very low CD4 count. Next. Also, herpes simplex infection can appear and may be recurrent in HIV infections. Herpes simplex infection, as you know, there are two types of herpes simplex infection. Type 1, that is appear in mucocutaneous lesions, perioral and perinasal, and the genital type. This is also common in HIV patients. This appear on the genitalia. It is vesicular lesions, multiple and painful lesions, and treated by a cyclovir. Also herpes zoster, multiple dermatomal lesions, very painful, may cross the middle line. Next. Other diseases can appear, systemic diseases, namely the tuberculosis. Tuberculosis is a common finding and a common association in HIV patients. It is a contagious disease, completely curable, and you should screen for pulmonary tuberculosis in any patient with HIV. Pulmonary tuberculosis may appear at any CD4 count, but extra pulmonary tuberculosis appears as stage 4, that is the advanced stage, and the CD4 count low. Extrapulmonary tuberculosis. Extrapulmonary tuberculosis may present with disseminated biliary tuberculosis, like this patient, and may cause wasting syndrome to advanced biliary tuberculosis, and also the same patient can present with chronic diarrhea and anorexia or cachexia due to malignancy, wasting syndrome. Pneumocystis pneumonia may be a presenting finding in stage 4 disease, in stage 4 clinical stage 4 HIV patients. Pneumocystis pneumonia is a progressive dyspnea and progressive desaturation that may lead to respiratory failure. And treated, this is a fungus infection, and very similar to COVID-19 in appearance of CTC, that is patient present with multiple ground glass appearance, and ultimately needs mechanical ventilation and treated with stream and also methylprednisolone. Next, clinical manifestation, I see fever, non-productive cough, and chest discomfort. Oral thrush is a common co-infection. Fever apparent in most cases and may be the predominant symptom in some patients. Next, hypoxemia is most characteristic lab finding and increase LDH more than 500 milligram per DL. This is the ground glass appearance, and the pneumocystis pneumonia, Girovici organism in bronchoalveolar lavage. Next. Cerebral toxoplasmosis. This is a common disease that the patient can present with severe neurological complications and multiple mass occupying lesions in the brain, subcortical in locations more than 3. The patient presents with lateralizing signs and progressive deterioration in the conscious level. And the lateralizing signs, CT and MRI can be a clue to diagnosis. And also serology, we can find that Toxoplasma IgM and IgG. Toxoplasma IgG is very, very high. more than 50 to 100 more than normal, because this is reactivation and IgM is slightly elevated. The MRI finding in cerebral toxoplasmosis more than 3 lesions and subcortical locations, we ring enhancing lesions. They are ring enhancing lesions. And also we can find a characteristic finding that is the eccentric ring sign. Eccentric ring sign. This is maybe a clue to diagnosis of cerebral toxoplasmosis. Differential diagnosis CNS lymphoma. That is CNS lymphoma is also common in patients with HIV, but it is commonly a single lesion. CNS toxoplasmosis is 3 more than 3 subcortex. This is the cerebral toxoplasmosis patient, and if you see this arrow, eccentric ring sign is one of the can be a clue to diagnosis. A treatment preferred regimen pyrimethamine 200 mg once, followed by dose based on body weight. Pyrimethamine plus sulfadiazine, leucovorin, alternative pyrimethamine, clindamycin, or trimethoprim sulfamethoxazole. And many other treatment regimens, but the most common is pyrimethamine and sulfadiazine, leucovorin. From opportunistic infections, also can find progressive multifocal leukoencephalopathy. This patient is specific to HIV. The patient, HIV patient, present with progressive dementia and occurs in CD4 count less than 100. And caused by GC virus, and patient present with coordination disturbance, cognitive impairment, and limb paresis, and MRI is characteristic. This is another picture of bilateral progressive leukoencephalopathy. Also, cryptococcosis. Cryptococcosis is a common finding in clinical practice. HIV patient can present with severe form of meningitis in the form of severe headache and meningeal signs, neck rigidity, and blurring of vision, and the worst headache you can see in your life. This patient can, the same patient also presented with skin lesions, that is cryptococcal skin rash, very resembling molluscum contagiosum, but it is ulcerative lesions. This patient was present in our ICU and presented with cryptococcal meningitis, and these skin lesions was cryptococcal skin rash, and also the same patient has cryptococcal pneumonia. Cryptococcal meningitis is patient present with very high intracranial pressure that necessitates daily lumbar puncture to relieve the intracranial pressure, and in addition to the treatment with cryptococcal meningitis that is in the form of amphotericin B and flucytosine that is not present in our country, and we can combine with amphotericin B and fluconazole in a large dose. Next, in clinical practice. Other diseases that are the common diseases: recurrent pneumonia, recurrent chest infections, recurrent tonsillitis, recurrent bronchitis, recurrent sinusitis. All are these common in patients with HIV. Thank you very much.
Thank you very much, Dr. Hamdi. This is a very nice presentation, and the real cases photos are really nice. Now we have noticed the importance of measuring the CD count and the different opportunistic infections that can occur at different levels of CD count. Now it seems to us that our patient is going to start his antiretroviral therapy. But when we are reviewing the investigations of this patient, we found that he had proteinuria and the glomerular filtration rate is less than 60. Now I'm inviting one of our eminent infectious disease and HIV consultants, Professor Dr. Mohammed Kamal Munir, He has an experience more than 15 years in the field of medical care in Egypt for people living with HIV in Abbasiyah Fever Hospital, and he's a member of the South African HIV Clinicians Society. By this finding, Dr. Kamal, in this patient, this glomerular filtration rate, is there any impact of this glomerular filtration rate on the selection of the antiretroviral therapy to this patient? And what are the possible side effects commonly occurring with the commonly used antiretroviral drugs in Egypt? Finally, what are the other comorbidities that can occur to this patient when he is on his antiretroviral therapy with maintenance of suppressed viral load and good CD count? What are the other comorbidities apart from those associated with HIV?
Bismillah ar-Rahman ar-Rahim. First of all, I thank Dr. Heba for the very nice introduction, and I thank the organizer committee for allowing me to give this presentation in front of you. In fact, it's very important question what you asked it for, because we all know that there is what we call pre-treatment investigation. The pre-treatment investigation, Dr. Zahabi mentioned some of them, which is the screening. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بداية أشكر اللجنة المنظمة وأشكر الدكتورة هبة عبد الله على المقدمة الجميلة. إن شاء الله يكون التوك يعجبكم. الحقيقة السؤال اللي حضرتك سألتيه سؤال في غاية الأهمية، هو يتعلق بأن إحنا نبتدي ال ART وال ART عشان نبتديها في pre-treatment very important investigation to be done. Including in part of it what mentioned by Dr. Amjad al-Zahabi, اللي هو screening for other viruses. والmost important viruses we usually meet with اللي هم ال HPV وال HCV in our society، خصوصا مع ال population at very high risk زي ال injecting drug user أو ال people who have sexual activity apart from marriage frame، سواء كان هيتيروسيكشوال او هوموسيكشوال. في الحاله دي احنا بنعمل سكريننج للفيروسز. والحقيقه انا حبيت اضيف نقطه بسيطه على كلام الدكتور امجد، ان السكريننج احيانا في اتش اي في بيكون مختلف شويه. احيانا بيكون عندي اوكالت اتش بي في انفكشن، فبالتالي ما اقدرش اعتمد على الاتش بي اس انتيجين، وضروري اعمل اتش بي في دي ان اي ثرو ذا بي سي ار علشان اتاكد انه كان في اتش بي في انفكشن، خصوصا اذا كنت شاكك في البيهيفير بتاع البيشنت. كمان في الاتش سي في ما اقدرش اعتمد على الانتي اتش سي في انتي بودي، لان هو في كتير من الاحوال بيكون فولس نيجاتيف، خصوصا في حالات السيفير اتش اي في. الحاجه الثانيه اللي احنا ضروري نعملها قبل ما نبتدي التريتمنت اللي هي تتعلق بالكدني فانكشن والليفر فانكشن، لان طبعا موست اوف ذا ريجيمز عندنا بيكون الباك بون اوف ذا تريتمنت عباره عن 2 نيوكليوسايد ريفرس ترانسكريبتيز انهبيتور، واللي موجود عندنا غالبا التروفادا اللي فيها التي دي اف التينوفوفير. التينوفوفير من الحاجات اللي بتتطلب انتاكت رينال فانكشن، يعني عشان انا ادي تينوفوفير كبارت اوف ماي ريجيم لازم على الاقل الجلوميرولار فلتريت ريت بتاعي يكون وزين نورمال والكرياتينين كليرنس اباف 60. اقل من كده هيبقى انا بضيف ريسك من النيفروتوكسيستي على الرينال امبيرمنت اللي موجود. كمان طبعا احنا ما بنديش العلاج فورا ونسكت، احنا بندي العلاج بعد ما نعمل البريباراتوري انفستيجيشن ديت ونتاكد ان كل شيء انتكت بما فيه السي بي سي والكدني فانكشن والليفر فانكشن والسكريننج للاذر فيروسز. كمان بعد مده خلال شهر بنعمل ريبيت للروتين انفستيجيشن زي الكدني فانكشن والسي بي سي والرينال فانكشن عشان نتاكد ان ما فيش بدايات لاي ادفيرس افكتس من الريجيم اللي انا استخدمته. الحقيقه طبعا حاليا الافكتيف انتي ريتروفيرال ثيرابي بتعني ان البيبل ليفينج ويز اتش اي في زي ما قالت الدكتوره هبه زي ار ليفينج مور ذان بيفور، they are having better quality of life and they span of life very close to the normal people. فبالتالي زيهم زي اي اشخاص عاديين زي ما سفر من الايدج ريليتد illnesses، وان كان بتظهر عندهم earlier than people who do not have HIV. ده بنقول عليه accelerated or premature aging. وده بنستخدمه عشان نوصف الحاله اللي ذكر منها الدكتور حمدي بعض اللمحات في ان شباب صغير يظهر عليه حاجات مثلا زي كارديوفاسكولار ديزيز او يظهر عليه هيربس زوستر، مع ان الحاجات دي دايما ريليتد واسوشيتد مع الالدرلي بيبول. واحيانا دي زي ما اتفضل حضرته بتكون هي البريزنتنج كيس علشان اشخص الاتش اي في عند هؤلاء الناس. الحقيقه كمان some people living with HIV نتيجه استمرارهم في العلاج لمده طويله. احنا عندنا بعض المرضى دلوقتي على العلاج in Egypt since 15 years or more. They are experience side effects when taking treatment for long duration. بعضهم السايد افكتس دي بتتمثل في حاجات نون كوميونيكابل ديزيز، بعضهم حتى بتوصل للشيب اوف ذا بيشنت نتيجه استخدام بعض الادويه اللي هي بتعمل نوع من التشينج في الفيجر بتاع البيشنت بتاعنا. بيعرفوا اي اكسبيرت من اول ما يشوف. They may also develop other condition مع الايجينج زي الكارديوفاسكولار ديزيز، زي الاوستيوبوروزيس، زي اللنج ديزيز والكدني ديزيز. الحقيقه الاتش اي في باي اتسيلف بيحصل النورمال ايجينج خصوصا قرب سن ال 50. هم بيتميزوا بتشينج في اللايف ستايل، بيميل العيان شويه للكسل، سيدنتري لايف، ممكن يكون عنده باد هابتس زي السموكينج او الالكول او دراج يوز. بالاضافه كده هوت بناخد كمان في الاعتبار البريزيستنت اميون ديسفانكشن اللي موجود والكونتينوس انفلاماتوري بروسيس اللي موجوده. كل ده بيؤدي الى البريماتيور ايجينج اللي احنا قلنا عليه. فالايجينج مع الايفكت بتاع الاتش اي في باي اتسيلف مع الايفكت بتاع الادفيرس افكت بتاع الانتي ريتروفيرال دراجز، كل ده بيؤدي الى اديشنال موربيديتي. with the progress of age بنبتدي نبص نلاقي احنا عندنا حاجه بنقول عليها انفلامو ايجينج بدل انفلاميشن، انفلاميجينج، يعني ميكشر ما بين الانفلاماتوري بروسيس اللي اتكلمنا عليها والايجينج اللي بيحصل زيه زي اي انسان تاني. ده يؤدي الى بقى ميني فاكتورز وكوموربيديتيز، على سبيل المثال دايابيتس ميليتس او اثيروسكليروزز بيحصل ايرلي شويه عن السن اللي احنا متوقعينه، مع كارديوفاسكولار ديزيز، مع كوجنيتيف decline as regards the mentality health، مع altered في البودي كومبوزيشن زي ما وصفت لحضراتكم، واللوس اوف موبيليتي مع اللي بنقول عليها ساركوبينيا، مع كمان الاميون ديكلاين اللي بتخليها عرضه لاذر اوبورتيونستيك انفكشن لو تهاون في الادهرنس از ريجارد التريتمنت. لو ابتدينا بالموست كومن يوزد فيرست لاين بيزك دلوقتي اللي هو دوليوتيجرافير بيزد ريجيم. الدوليوتيجرافير از فيري افكتيف وذ ليست سايد افكتس، وكمان تقريبا نو ريزيستنس، ولكن في مشاكل ظهرت مع استخدام الدوليوتيجرافير وتعميمه على المرضى. من ضمن هذه المشاكل الويت جين، وخصوصا مع الفيميلز. هنلاقي ان في الاستادي بتاعت ادفانس اللي هي اتعملت في ساوث افريكا كان في دراسه مقارنه ما بين الدوليوتيجرافير بيزد ريجيم اللي هم بالاحمر وبالازرق والافابرانس بيزد ريجيم، ولقينا ان المين انكريز في الويت كان اكثر من 12 كي جي في خلال 96 اسبوع من المتابعه، ما يدل ان استخدامه ادى الى ويت جين. الويت جين باي اتسيلف مش مشكله، ولكن اللي بيترتب عليه بعد كده وخصوصا ويز ايجينج اللي هو انكريز في البودي ماس اندكس والاوبيزيتي، اللي بتؤدي الى مشاكل من قبيل الديابيتس والكونري فاسكولار ديزيز، وتؤدي اذا اجتمعت مع بعضها ومع الاتش اي في الى مورتاليتي. الريسكس اللي عندنا بتاعه الكارديوفاسكولار ديزيز كتيره جدا واسوشيتد واستدد ويل مع البيبل ليفنج وذ اتش اي في، ومنها على سبيل المثال مايوكارديال انفاركشن والهارت فيلير والستروكس والاذر كومبليكيشن. والسبب الرئيسي في كده زي ما قلنا كرونيك انفلاميشن اللي موجود والاميون ديسريجوليشن، بالاضافه للكلاسيك ريسك فاكتورز اللي هي زي السموكينج وزي الالكول وزي الدراج ابيوز اتسترا والسيدنتري لايف از ويل. الدايركت كونسيكونسز اوف اتش اي في بروفد ان ماني ستاديز، ووجد ان الكارديوفاسكولار ديزيز هو من احد اهم الاسباب اللي بتؤدي الى الوفيات حاليا بعد ما كانت الوفيات نتيجه الاوبورتونستيك انفكشن مينلي، اصبح دلوقتي النون كوميونيكابل ديزيز ليها بارت مهم جدا جدا في المورتاليتي، ايدز ريليتد مورتاليتي. من الاي ار فيز اللي هي ارتبطت بحدوث كارديوفاسكولار ديزيزز اباكافير. الاباكافير يوز هاز بين اسوشيتد ويز كارديوفاسكولار ديزيز، بالذات الاسكيميك هارت ديزيز، وعشان كده هو كونتر انديكيتد في الحالات اللي هي مشابهه. كمان كان في اوبزرفيشن كوهورتس اتعملت كتيره جدا جدا على الاسوشيشن بين البروتياز انهبيتور والكارديوفاسكولار ديزيز، خصوصا ان معظم هذه البروتياز انهبيتورز وخصوصا اللوبينافير بتؤدي الى ارتفاع كبير في الليبيد بروفايل. وبهذه المناسبه بنذكر الكاتيجوريز المختلفه. فبالنسبه للنيوكليوزايد ريفيرس ترانسكريبتيز انهبيتور اللي هي مستخدمه سواء التي دي اف او 3 تي سي او الاف تي سي او غيره، ما وجد ان تاثيرها على الليبيدز تاثير ضعيف جدا وضئيل، مش مهم كلينيكيا. وكذلك برضه النون نيوكليوزايد ريفيرس ترانسكريبتيز زي النيفيرابين او الدورابيرين او البروتيز انهبيتور زي الاتازانافير. يعني ما بين البروتيز انهبيتور اقل واحد ممكن يؤدي الى ديسليبيديميا هو الاتازانافير بوست ريتونافير. كمان الانتجريز انهبيتور وجد ان تاثيرها على الليبيدز قليل جدا بكل اشكالها اللي موجوده عندنا، سواء الدولوتيجرافير او الرالتيجرافير او البيكتيجرافير. السي سي ار 5 انتاجونست مش موجودين عندنا. ولكن لو تكلمنا على الاي ار بيز اللي ليها انترميديت افكت على الليبيد بروفايل، يعني وانا بديها لازم تو كيب ان اي على الليبيد بروفايل قبل استخدامها واثناء استخدامها. هنلاقي من ضمن الان ار تي ايز الاباكافير وزيدوفودين، ومن ضمن النون نيوكليوزايد ريفيرس ترانسكريبتيز انهبيتور الافافيرانس، ومن ضمن البروتيز انهبيتور زي ما قلنا الدارونافير كانترميديت افكت، على عكس اللوبينافير اللي هو يعتبر الهايست افكت. وبالتالي وجدنا حالات كتير اثناء علاج المرضى عندنا في مصر اللي هم حصل لهم ديسليبيديميا، وصلت في بعض الاحيان الى سكاي هاي فيجرز اوف توتال كوليسترول والترايجليسيديميا، وادت احيانا الى اكيوت بانكرياتايتس. طيب من ضمن النون كوميونيكابل ديزيزز برضه الاسوشيتد وارتبطت بالاتش اي في التايب 2 دايابيتس ميليتس. والريسك فاكتور فور تايب 2 دايابيتس ميليتس انكلود ماني فاكتورز، من ضمنها السينيليتي. وزي ما قلنا هنا بيبقى فيه بريماتيور سينيليتي عندنا من 45 سنه لازم نبتدي نعمل سكريننج للديابيتس في المرضى بتوعنا، كمان بالذات اللي هم عندهم فاميلي هيستوري اوف دايابيتس او عندهم انكريز في الويت. ودي التوصيات اللي هي بتاعت الايدز سوسايتي، ان لابد نعمل سكريننج اند دايجنوزز ايرلي للدايابيتس among people living with HIV، خصوصا في ايوه.
Some of the attendees are not very well with the some Arabic words. Please keep in English.
Okay. If we come to the HIV and bone health, we can find that HIV-infected persons have 3 times greater prevalence of osteopenia, osteoporosis, and than the HIV-negative population. Because of that, we have to look to this problem, especially when we are treating such patients. And in particular, women, because the risk of osteopenia, osteoporosis, and fracture, particularly after the menopause, is much greater than the normal population. HIV-related risk factors for low bone mineral density include low CD4 cell count, loss of bone mineral density that is observed particularly with tenofovir use, TDF, and mainly in the first year of treatment. Many treating physicians think that this will be due to accumulation of effect of tenofovir difumarate, but this is starting from the first year. You have to monitor it at least annually. And this especially because most of people living with HIV have low vitamin D, which is prevalent in a percentage as high as 60 to 75%. percent. So we have to look to the patient in general, not only as regards the HIV control and the viral suppression. We have to look to the non-communicable diseases, especially when I know that some of the ARVs I give have side effects. You cannot give treatment that you ignore what its adverse effects. You should not tell the patient about it, but because you know it, you have to be cautious and to monitor that effect in your patient. It is not happening to 100% of the patient, but at least you have to keep in mind. As regards the gynecological health issues and HIV affect many aspects in women living with HIV. The most important of them is the menstrual cycle, because some of them enter menopause younger and have more severe hot flashes and may have also drop in estrogen. And drop in estrogen found to affect the CD4 count. Women living with HIV also may experience missed periods. They experience lighter or heavier bleeding and severe premenstrual syndrome. And as regards fertility, it has been proved that HIV-infected women are 25 to 40% less fertile than HIV-negative women. And HIV affects as well the ovulatory cycle and may cause even amenorrhea and ovarian failure. Because many of the patients have history of STIs rather than the HIV, we may find by investigation infertility that there is a fallopian tube blockage or uterine scarring. So we have to put this in mind. Other issues include the stress and increased maternal age, also the weight loss. We come to very hot topic and very important one, which is the cancer among people living with HIV and AIDS. We can divide this into two categories. The AIDS-defining cancers. Dr. Hamdi, he spoke about AIDS-defining illnesses, and some of them like esophageal candidiasis, like extrapulmonary TB, like pneumocystis cardiae pneumonia. Also, there are some AIDS-defining cancers, and the most famous of them is the Kaposi sarcoma, non-Hodgkin lymphoma, and cervical cancer. But in HIV also, there are some non-AIDS defining cancer. What's meant by non-AIDS defining cancer? These are cancers that can happen even without progression to AIDS, even with a normal CD4 count, or a viremia that is not very much severe. Some examples of them are Hodgkin lymphoma, anal cancer, especially with men have sex with men, liver cancer, especially with people have co-infection with hepatitis B or hepatitis C, head and neck cancer, especially with people having drugs and heavy smokers, kidney cancer, etc. We take an example of this AIDS-related cancer. The most famous one is the cervical cancer. And cervical cancer is one of the AIDS-defining illnesses. And it is common because up to 75% of HIV-positive women have human papillomavirus that puts them at a high risk for developing cervical cancer. The HIV-positive women are 5 times more likely to develop cervical cancer than compared to the negative one. And cervical carcinoma progresses twice as quickly as HIV-positive women. That's why the WHO launched a slogan by 2030 control targets. This target is very ambitious, and on which they wish that 90% of girls could be vaccinated by the human papillomavirus vaccine by age of 15 before 2030, and 70% of women at 35 years old or 45 years old also get tested for screened for human papillomavirus, and 90% of those could also treat it. It is this slogan called screen and treat. Treat what? Treat the precancerous lesions using cryosurgery. And if there is a cancerous lesion, it could be detected earlier and sent for treatment by oncologists. The non-AIDS defining cancer are now having another or additional risk factor because of HIV. And because of HIV aging and there is anti-chronic inflammation and immune system dysregulation and oncogenic viruses such as HPV or HCV or human papillomavirus or Epstein-Barr virus, this cancer become common among our population of HIV. Also, high-risk behavior such as tobacco and alcohol or drug use, as we mentioned. That's why there is a lot of effort should be done to treat these cases. We come to one of neglected non-communicable diseases, which is very common among our patients, which is the depression. Depression is very common among our patients, especially after knowing about their diagnosis that they are HIV positive. And depressive disorder are the largest source of mental health disease, and it is co-occurring with HIV and contributing to greater morbidity and mortality. And the people who are depressed are 3 times more likely to be non-adherent to ART compared to those who are not depressed. That's why it's very important to diagnose depression early and to do this. This is not the function of the primary HIV care clinician. When he notices such a thing and want to give a favor to his patient, it's better as a part of multidiscipline work to refer to psychiatric consultation in order to confirm the diagnosis and give the necessary treatment to overcome this, because we need the patient mentally healthy and to keep the excellent adherence to treatment. Another important problem, which is related also to CNS, the HIV-associated neurocognitive disorder, or what is abbreviated as HAND. Actually, there is little known about how HIV affects the brain, but even with people living with HIV, they are, if they are not on effective treatment, or if they are on effective treatment, some of them still have an increased risk of developing a neurocognitive disorder. The severity of this condition can range from occasional memory loss up to complete dementia. So a neurological specialist can conduct a range of cognitive tests to determine the diagnosis and to give the necessary care. HAND appears to be more common among people co-infected with HIV and hepatitis C, as mentioned in some studies. In fact, to conclude, we need to save lives of our patients, but saving lives of them by using successful ART is not enough. We shall also keep them alive by not losing them to non-communicable disease that may be a reason for mortality. Also, providing the non-communicable disease care as a part of existing and functioning HIV care system could be logistically simple, as mentioned by Dr. Heba, by creating integrated clinics. الحقيقة الانتجريتد كلينكس مهمة، بس يعني اللي عرضته الدكتورة هبة كان ان يبقى في انتجريتد كلينيك للاس تي ايز وللتي بي كو انفكشن مع الاتش اي في. ده طبعا في المرتبة الأولى في الدول اللي التي بي والاس تي ايز ريبريزنت عندهم مشكله كبيره جدا جدا. انا سافرت في اكتر من بلد في افريقيا، ودول مشكلتين كبار جدا جدا وبيعيقوا مسار العلاج. We have another similar problem here, which is hepatitis infection. So what I suggest is to start with integrated clinic, HIV hepatitis clinic, that is covering this very important and common co-infection in Egypt. Also, a package for non-communicable prevention, screening, and management is required. الحقيقة, my advice to all physician dealing with HIV is to listen to your patient and keep in mind the non-communicable disease. complaint بتاعت البيشنت ممكن تكون due to side effect, ممكن تكون due to other comorbidity. You have to listen to it, especially if it is adverse effect. You will not realize this problem unless you know this adverse effect of different ARVs. And listen and respond, because this is long life treatment. You cannot ignore it. And sometimes you may need to switch علشان العيان يبقى more comfortable ويبقى more adherent للعلاج بتاعك. Thank you very much.
Thank you very much, Dr. Kamal. This is a very nice presentation with a high clinical experience. And as we noticed that our patients are managed with the HIV clinician, but sometimes we will need a multidisciplinary team to work for this patient with other specialties to correct many of the problems he is facing. Now, Dr. Dua, our patient is going to receive the treatment of hepatitis C. He may receive a prophylaxis or treatment to some of the opportunistic infections, antiviral or antifungal or antibiotics. He may experience diabetes or dyslipidemia or other comorbid conditions that require other treatments. So our patient is facing the problem of polypharmacy. Dr. Dua Abdelaziz, the head of clinical pharmacy at the National Hepatology and Tropical Medicine Research Institute, please summarize to us the issue of polypharmacy, drug-drug interaction in people living with HIV.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Heba. I would like to thank all the attendees, the chairpersons, moderators, the speakers for this kind invitation. Actually, this is a very important point to consider during our managing our patients for HIV. In order to answer your important questions, especially regarding the management of DDIs, it will depend on the mechanism of the possible drug-drug interactions, whether it's going to affect the absorption of the medication, or then I can make some dose spacing in order to manage, or this will give me an adequate action. If it's concerning enzyme metabolism, either enzyme induction or enzyme inhibition, then might consider changing the therapy or dose adjustment for one or both of the medications, or either in the case of no other alternatives, we might conduct a close monitoring plan for our patients. Okay, this will be a brief. This will be a brief lecture about the art of interpretation, and I will try to make it a practical approach. Before we start, let's see some case like a woman with HIV stable on atazanavir, ritonavir, and the tenofovir emtricitabine. And then she realized the elevation in the total cholesterol and LDL. She has a strong family history of cardiovascular disease. Her father had myocardial infarction at the age of 52. She does not want to consider any change in her antiretroviral regimen, but agrees to start a lipid-lowering therapy. Let's think with each other which one of the following statins is contraindicated for use in this woman, whether atorvastatin or simvastatin or pravastatin or rosuvastatin. Actually, before we answer, we need to understand the art of the interpretation. In order to reach the right interpretation for my drug-drug interaction, so I can give the right recommendation for the physician, so I am going to reach the best patient care. We need to know just briefly, the classification of drug interactions. Drug interactions actually occurring in vivo are generally classified as pharmacokinetics or pharmacodynamic interactions. Pharmacokinetic interactions means that the two medications, when given to each other, the precipitant drug will affect either the absorption or the distribution or the metabolism or the elimination of the medication, of the other medication. The second classification of the drug interaction is the pharmacodynamic interaction, where the effect of the drug is changed by the another medication, producing an antagonistic effect, synergistic effect, or additive effect. Before we start to understand what is the art, we need to know some terms related to the drug-drug interactions. We need to know that there is something called potential drug-drug interaction. When I say potential drug-drug interaction, then the two medications are supposed to have interaction or known to interact with each other. That may occur and may or may not occur in the exposed patient. This because the data from the drug-drug interaction potential, which led to potential drug-drug interaction, might be relied on animal studies, might be relied on a small number of subjects. Maybe the medication have the same metabolic pathway of the other medication known to studied. So they build their recommendation upon these things. Sometimes the potential drug interactions also because of the expecting interaction, which means that I have a precipitant drug known to be a cytochrome inducer or known to be cytochrome inhibitor, and the object drug is known to be metabolized by this enzyme. So I'm expecting to have a potential drug-drug interaction. While in the clinically relevant drug-drug interaction, the two medications have been tested together. When we are testing medication for possible drug-drug interaction, we are giving the medication alone for healthy volunteers, and we are withdrawing blood samples on scheduled intervals, and we are going to start draw this curve. Then, for the same healthy volunteers, we are going to administer the same medication with the co-administered medication supposed to have a particular drug-drug interaction. And then try to draw the same curve and then compare the two curves with each other. The magnitude of the change which happens in the exposure or in the systemic exposure of the medication, comparing the drug alone with the drug supposed to interact with each other, then we determine the drug-drug interaction after comparing this. The magnitude of the change, either by increasing or decreasing, is a risk-benefit ratio. What's meant by risk-benefit ratio? This will require, the final decision will require the clinical judgment of the clinician who is going to deal with this drug-drug interaction. This will determine his action, whether his action will going to be changing the medication or adjusting one or both of the doses, or just conducting a monitoring plan for his patient, as well as conducting the frequency of monitoring for the patients. The common mechanisms for pharmacokinetic drug interaction, which is the main class for drug interactions, mainly involving the absorption of the medication. When I'm going to administer a drug causing a change in the gastric pH, this might affect the absorption of the other medication and decrease its systemic exposure, like in the PPIs. Some medications make a drug interaction regarding the absorption في chelation, which requires the divalent cations, like drugs with magnesium, ferric, aluminium. The second issue, or the second part في drug interactions, pharmacokinetic drug interactions, will be the distribution, and there is some conditions must apply if the drug is to be displaced from its carrier protein by another drug. Both drugs should bind to the same binding site, and the displacing drug must have the higher affinity for the binding site of the other medication. The drugs involved in drug-drug interaction requiring the distribution which result in significant drug interaction are mostly the drugs highly protein bounding, more than 90%. Those with the narrow therapeutic index, these are more likely to result in significant drug interactions. Like albumin, for example, is basic, and so it will bind to the acidic medications. Examples of medications that are highly bound to albumin, including warfarin, digoxin. So any hypoalbuminemia in your patient will increase the free free active part of the drug, and so it will more pronounce its action. Something like transporters, for example, of OATPs, organic anion transporting polypeptides. This provide uptake through the hepatocyte membrane, providing access of the medication for liver metabolism. And the most significant of these in terms of drug interaction are OATPs 1B1 and 1B3, which distributes drugs to the liver. Most importantly, the drug-drug interaction involving the drug metabolism, which known as the enzyme inhibition or enzyme induction. The precipitant medication will go to inhibit, is a potent enzyme inhibitor. So it will going to inhibit the metabolism of the substrate medication supposed to be metabolized by this enzyme. Or enzyme induction, supposed to induce the enzyme responsible for metabolism of the medication, and so the concentration of the object drug will be decreased. There is some information should be emphasized in this place, where we consider actually the half-life of the precipitant medication, the drug going to either induce or either inhibit the enzyme of the enzyme responsible for metabolism of another medication. We are considering the half-life of the precipitant drug in order to estimate the time required to maximize its effect on an enzyme. For example, if I have an enzyme inhibitor with half-life of 6 hours and I need about 3 to 5 half-lives in order to reach the steady state, then actually we will need about 30 hours to reach the steady state and to reach or to exert for the medication to exert its maximum inhibitory effect on the enzyme. So when I'm dealing with enzyme inhibitors, I am expecting that inhibition will happen just after a few days. On the other hand, there is a little bit difference when we are dealing with enzyme induction. The time required to produce the maximum enzyme induction is much longer due to the requirement of more and more additional enzyme production, which reach in most of the medications up to 4 weeks. Actually, this is important when I am deciding a monitoring plan for my patient, because this will affect the frequency of monitoring. When I'm dealing with enzyme inhibition, or I'm expecting enzyme inhibition between the two medications, then I'm going to closely monitor my patient in just a few days following the co-administration. While when I am dealing with enzyme induction, then I am expecting to closely monitor my patient up to the first 4 weeks in order to reach the time required to produce the maximum enzyme induction. Actually, there are online websites for checking the drug interactions. One of them related to the United States, which is Lexicom. Lexicom can be entered from Egyptian Knowledge Bank, where you can enter to the up-to-date and then to the Lexicom that is the drug information resource for the up-to-date. Another important online site is the HIV drug interaction conducted by University of Liverpool. And it's a free online site. You can find it also on mobile, as a mobile application, either on App Store or Google Play. When I'm expecting a potential drug interaction, I am going to see it's clinically relevant or not. I should consider the size of the dose I am going to use. For example, when we are dealing with a drug interaction with the PPIs, we can see that the drug interaction can be happened on omeprazole, for example, dose 20 milligram, and it's equivalent. So I cannot use higher doses of this medication, because this will subject my patient to more and more drug-drug interactions. The onset of the drug interaction, as we said, is it rapid or it is delayed, and the severity of the potential interaction. The severity of the potential interaction, if we are dealing with enzyme inducers, for example, and it's going to decrease the concentration of one of the antiretrovirals medication. So this is an important interaction I can consider. On the other hand, if I'm going to deal with enzyme inhibitor and it's going to increase the concentration of the co-administered medication, just like metformin, for example, okay, I can monitor the I can monitor the adverse effects of the metformin, like more closely monitoring for the renal functions of my patients. Actually, the main side effect of metformin is lactic acidosis, which is rare happening in my patient. So all of these items should be considered in order to consider the clinical relevance of any potential drug interactions. Actually, there are various factors that might influence the occurrence of the interaction or the severity of the interaction, like patient-specific variables like organ dysfunction, renal dysfunction. Patients with renal dysfunction will be affected more with if I'm going to use the medication with making a drug interaction with tenofovir, it will increase the concentration of the systemic exposure of the tenofovir in patients. So this is more likely pronounced in patients with renal dysfunction. The same in hepatic dysfunction patients. Smoking as well is enzyme inducing by itself. Some patients are poor metabolizers for some SEP or some cytochrome enzymes. Additional factors might relate to specific pharmaceutical dosage forms. For example, dolutegravir is making an interaction with the vitamin B12 only if it is in multivitamin component, but if it is taken with vitamin B12 alone, it's okay, there is no drug-drug interactions. But dolutegravir with multivitamins, with vitamin B12 in dosage form, multivitamins dosage form, then this can reduce the exposure of dolutegravir. I might change the dosage form or change the route of administration and give the patient injection of vitamin B12 instead of oral medication. So highlighting this information actually enables the clinician dealing with the drug-drug interaction to more thoroughly evaluate the interaction relevance for every specific patient. This rating rates the risk of the drug interactions. It's a rapid indicator regarding how to respond to the interaction data. Whether I'm going to deal with lagzik.com, it's just classifying the interactions A, B, C, D, X, where A and B are not of clinical concern. They are equivalent to no interaction expected when I am talking about University of Liverpool interaction checker. When I'm going in the lagzik, there is the C or D and X. This require attention of the clinician. might be a potential weak interaction in Liverpool interaction checker, or X category mainly equivalent to do not co-administer in the interaction checker of University of Liverpool. What this risk rating means and what are our action. It's not unknown, not known interaction. Data have not been demonstrated, either pharmacokinetics or pharmacodynamics between these specific agents, while B is data demonstrates that specific agents might interact with each other, but there is no evidence, or there is little evidence of clinical concern resulting from their combining use, and no action will needed. Category C, this is monitoring the therapy, where data demonstrate that the specified agents might interact with each other in a clinically significant manner, and the benefits of the use of these concomitant medications outweighs the risk. Appropriate monitoring plan should be implemented in order to identify the potential negative effects on my patient. The dose adjustment may be needed in some minority of the patients. Class D, its my action will be considered therapy modification. Data demonstrates that the two medications might interact with each other in a clinically significant manner, and a patient-specific assessment should be conducted to determine whether the benefit of the concomitant therapy outweighs the risk. Specific action might be taken in order to realize its benefits and minimize the toxicities resulting from the concomitant use of these agents together. These actions might include aggressive monitoring plan, empiric dosage change, or choosing alternative agents. Category X, which is avoid combination or equivalent to do not co-administer in the Liverpool interaction checker, where data demonstrate that the specified agents might interact in a clinically significant manner, and here the risks outweighs the benefit and are generally considered the contraindicated. How to manage my drug-drug interaction? First of all, we should review the patient profile. We should review the drug history of my patient, the comorbidities and the medications the patient are taking, including the OTC medications. We should review the patient risk factors. We should avoid complex therapeutic drug regimens, and should determine the probability of any clinically significant drug interactions and suggest a different medication if there is a high probability for a clinically significant drug interaction. Also, we should carefully instruct the patient about the timing of the medication. For example, when we're taking antacid with some of the antiretroviral medications, should use the maximum spacing time between the drugs. And for better patient care, in my opinion, if it is possible, you are talking all the previous sessions about multidisciplinary teams. So if it is possible, we can involve a clinical pharmacist in the HIV, HCV evaluation clinics. This will save your time managing your patients in a better way and minimizing their drug interactions. Also, I would like to highlight here about reporting the adverse drug reaction throughout your work. When you are going to work in your clinic and you face an adverse drug reaction due to drug interaction, you should report this to the pharmacovigilance center, and it has a website on the Ministry of Health and Population website, where you have to report the adverse drug reaction happened. Let us see the examples of the common medications taken with my patients, especially the patients, for example, the patients co-infected with HCV. We can see that dolutegravir with emtricitabine and tenofovir. We can use sofosbuvir, daclitazvir safely with this combination. We can use use also Harvoni safely with this combination. Take care with the analgesics of your patients, because the patients can get analgesics as OTC medications from any pharmacy. So they should know that paracetamol is the most safe analgesic. As you see, the green color represents that there is no possible interaction with most of the antiretroviral therapy. Something like tramadol also is a potent analgesic for your patient, and it is safe in most of the combination antiretroviral therapy. Something like naproxen or diclofenac, sometimes it can cause potential drug interaction with this amber color. This potential interaction almost dealing with the diclofenac is renally eliminated, and the tenofovir is also this combination might increase the chance of the patient to get acute kidney injury. So you can monitor if there is no chance to change the medication for your patient, or change the analgesic, for your patient, then it will be possible to closely monitor your renal function of your patients. This is an example for the antiarrhythmic medications co-administered with HIV possible combinations. We can see that amiodarone here with the atazanavir boosted with ritonavir is do not co-administer, or the red color. And when we are talking about emtricitabine tenofovir, we can see a potential interaction. Let's see what is this. We do not stop at that. These medications are not co-administered with each other and stop talking. No, we can press on this. Press on this interaction and see what is going to give us. When we press this in the interaction checker of University of Liverpool, we see that amiodarone with atazanavir, ritonavir are under the title of do not administer. But this is the quality of evidence is very low. And the co-administration of these two medications actually has not been studied with each other. It's not recommended, and it is given the sign do not co-administer, because the possibility of this interaction will increase the concentration of the amiodarone, and so this is associated with a serious and life-threatening event, including the cardiac arrhythmia. Although if amiodarone is the only option for my patient, therapeutic concentration monitoring might be required. On the other hand, amiodarone with emtricitabine and tenofovir combination is a potential interaction, or also with a quality of evidence very low, and the co-administration has not been studied, but actually the solution would be monitoring for the adverse events of the tenofovir, which might include frequent renal monitoring due to the possible increase in systemic concentration of tenofovir. This is some of the antibacterials we are facing all the day with patients with HIV drug interactions. We can see that amoxicillins are safe, azithromycins are safe in most of the combinations. We can see also third and the fourth generation cephalosporins are safe with all of the antiretroviral therapy. Ciprofloxacin also is safe with these combinations. Augmentin or clavulanic acid, or the amoxicillin, which is augmentin, is also safe in our patient. Linezolid is safe with all the combinations. Metronidazole is safe in most of the combinations. When we are talking about the anti-TB medications like rifampicin, I can see that most of the medications with a significant drug interactions. Let us see rifampicin with atazanavir, ritonavir. They give us the sign of do not administer. Here the quality of evidence is moderate, so will get more attention. The co-administration is contraindicated and not recommended. We can see under the title of do not co-administer either the expression of contraindicated or the expression of not recommended. So when I see the expression of contraindicated, I'm suggesting that actually the actual two medications have been tested in my patient, and the exposure have been changed a lot, as we see that the atazanavir concentrations have been decreased significantly, reaching 98% when we talking about the C minimum, because this
Well, we are just waiting. We have only 2 minutes.
Okay. Okay, this can result in some virological failure and resistance development, because they, during the attempts to overcome this decreased exposure, they saw a lot of liver reactions. That's why it's written do not co-administer. For the anti-diabetic medications, for example, we can see a lot of medications without drug interactions. As I told you in the first of my session, that metformin with dolutegravir is a potential interaction, but actually this potential interaction can be managed easily by monitoring my patient more frequently as well. This is also for the antifungal medications. We can see voriconazole with evavirans making a potential interaction managed by increasing the maintenance dose of voriconazole to 400 twice daily and decreasing the evavirans dose to 50%. This is the interaction of beta blockers, where atenolol with dolutegravir will require starting the atenolol with a lower dose, while with atazanavir, ritonavir, it's only ECG monitoring for your patient. With calcium channel blockers for amlodipine with atazanavir boosted with ritonavir, just monitoring for the ECG of your patients. My last slide will be talking about the steroids. Sometimes we are not checking the interaction of the only we are checking the interaction of the orally medications. Actually, the steroids where the inhaled forms of steroids like fluticasone, for example, have a major interaction with atazanavir, ritonavir. So please, when you are going to check your patients' co-medications, check the inhaled medications, the oral medications, and the intranasal medications. For example, there is a do not co-administer sign for fluticasone with atazanavir, ritonavir, which require switching to another glucocorticoids, not substrate for CEP3A4, like beclomethasone. The last slide will be the answer of my first question, which is lipid-lowering agents, drug-drug interactions with HIV. We can see most of them are can be taken safely with many of the antiretroviral medications, and we can see the answer of our question, which will be simvastatin is the contraindicated drug, statins or lipid-lowering agent when taken with atazanavir and ritonavir. Thank you so much, and I hope you enjoy my presentation.
Thank you very much, Dr. Dua, for this highly informative lecture, and I think we need a separate meeting to go through all the details of this important issue. I'll just repeat your sentence about the incorporation of the clinical pharmacist in the multidisciplinary team dealing with the patient of HIV. Just I need to share screen finally to close the session. Finally, I think we have covered all the issues of our agenda. going to conclusion that the HIV continuum of care illustrates a fall of points in care, but also shows opportunities for intervention by primary care clinicians. People living with HIV may have an increased risk for developing comorbidities compared to the general population due to HIV disease and the use of the long-term antiretroviral therapy, as well as the other conditions similar to those without HIV, sharing the same comorbidities. And finally, the importance of integration of the clinical pharmacy to modify the drugs used in those patients. I'll just close the session with this lovely drawing by the daughter of my dear colleague, Dr. Ahmed Al-Kurdi. This is a nice, bright drawing. I hope the future for people living with HIV will be as bright as this photo. Now I invite you to attend the next session with Dr. Ahmed Kurdi, Professor Dr. Maisa Abdallah, and Professor Shakroun. And thank you very much for your attendance.
Okay. Hello, everybody. We are now coming to the second panel discussion of today's meeting. And now we are going to talk about the controversial issues in the management of HIV/AIDS in short. Let me firstly introduce my dearest professor, Professor Maisa Abdallah, Professor of Hepatogastroenterology and Infectious Disease at Zakazig University, the chairperson of this second part. And I'm inviting her to introduce our valued speaker, Professor Shakroun.
Good evening, everybody. Thank you so much, Dr. Ahmed Kurdi, for your nice introduction. It's my pleasure to introduce Dr. Mohammed Shakroun, Head of Infectious Disease Department at Fatuma Bourkeba Teaching Hospital, Tunisia, and also he is University Professor, Teaching and Faculty of Medicine of Minister Tunisia. Welcome, Dr. Shakroun.
So now we are going to start our discussion, and we are going to address 3 points. I'd like to start with the first point about the vaccination. And you know, Dr. Shakroun, that we have shared with each other a very interesting study about the effect of COVID-19 on the people living with HIV in the area of Middle East and North Africa. And you know that we have reported that we have a very few number, maybe only 13% of the people living with HIV have reported to receive the influenza vaccine. So what's your comment and your recommendations to our colleagues from the healthcare workers who are providing care for people living with HIV, either in Egypt, Tunisia, or any other part of the world?
Thank you very much for the nice introduction, and thank you for this invitation. It is a pleasure to attend this important event to celebrate the World AIDS Day in Egypt. To answer to your question, I think influenza vaccine is a main question now in COVID area, and many people living with HIV asked if they need to be vaccinated with the influenza vaccine. I think it is better for people people living with HIV to be vaccinated and to be protected against influenza. But we don't have many data about interaction between COVID-19 and influenza. So having the vaccination on influenza will perhaps reduce the risk of COVID-19 and influenza co-infection in these people. About HPV, I think now we have more and more data about the need and the efficacy of this vaccine. As you know, human papilloma virus is the most common viral infection in the reproductive tract. Also, people living with HIV are at most risk of HPV infection, and this infection may cause more complication as cervical cancer, especially when the human system is weakened. And cervical cancer is the second most common cancer in women living with HIV, especially in the developing countries. Vaccination with HPV might be very beneficial for this population, but unfortunately, this vaccination is not yet available in our region and in our countries because it's very, very costly. Hepatitis B vaccination also is a very beneficial vaccination, and some countries recommended to screen for hepatitis B at the initial test before starting ERT. But unfortunately, people living with HIV are not receiving hepatitis B vaccine because it's not covered by medical insurance in many countries. In my country, for example, we cannot offer hepatitis B vaccine for people living with HIV, but I recommend to use this vaccination for people living with HIV to protect them from the risk of hepatitis B, especially for key populations. Over to you.
Yeah, I think this is it's our duty, Dr. Chacroun, that we have to encourage the availability of these vaccines. You know, it's the best way to make prevention for two of the most dangerous cancers, either the cervical cancer in women or the hepatocellular carcinoma in the people who may get infected by hepatitis B and HIV co-infection. So if you can give us like an in one sentence, what about the vaccination and what should the healthcare worker not to forget about the vaccination when he is talking or managing his patients who is coming to receive the care for the HIV?
I think if I summarize what I said, we need or we recommend to vaccine against influenza this year, especially this year. Yeah. We have to advocate for HPV vaccine and hepatitis B vaccine in our region, and we have to recommend this. But unfortunately, many of people living with HIV don't have medical insurance, so they don't have also money to purchase and to be vaccinated. So health system in our countries should offer this vaccine free.
Yeah, fortunately in Egypt now I think we have major steps in for the availability of the hepatitis B vaccine. I think Dr. Maisa may have comment about this. Dr. Maisa, are you hearing me?
Dr. Maisa?
I can't hear you, Dr. Kurdi.
I was telling Dr. Chacroun that we in Egypt we have a great steps for the availability of hepatitis B vaccine for the general population. What's your comment about this?
I think it's very important to recommend the hepatitis B vaccine among people living with HIV, because you know it's one of carcinogenic virus to protect our patient against HCC. And I think it's available, but it will be offered free for HIV, and this is my recommendation for the Egyptian Committee for Fighting HIV. Yeah. Especially for those who are at risk of getting hepatitis B virus infection, Dr. Kurdi.
Yeah, that's right. And I think that the National Committee for Combating Viral Hepatitis in Egypt now is making a great effort for the availability of the hepatitis B vaccine for the general population on one hand, and for the at-risk population like the prisoners and the key population like the people living with HIV on the other hand. But I think we still, all the regions need to make more effort for the availability of the human papillomavirus vaccine. But by the end of the day, I think all of our participants from the healthcare workers should focus on the vaccination and should talk to their patients about the need to receive the vaccine and encourage them to do this. When we come to the second part of this discussion, we are going to talk about the PrEP, the pre-exposure prophylaxis. And I'd like to ask Professor Chacroun, what do you think about the concept of having PrEP? You know, we have some cultural barriers in our region about the PrEP, and some are talking about if you are providing PrEP for the patients, we may be encouraging them to go for unethical behavior or something like this, or risky activities. So what do you think about the concept for PrEP and its availability?
Thank you very much for these great questions. PrEP is the use of antiretroviral medication to prevent the acquisition of HIV infection by an infected person. And the PrEP is highly effective in preventing sexual transmission of HIV. And while PrEP can prevent HIV, it does not protect against other sexual transmitted infections, as syphilis, gonorrhea, and other sexual transmitted infection. PrEP is now available on tablets, combined tenofovir 3TC or tenofovir antricitabine, in the vaginal ring of dapivirine, and also cabotegravir injectable. But the most used PrEP is now tenofovir antricitabine or tenofovir 3TC tablets. And since PrEP should be used for uninfected people, people should be tested for HIV before using PrEP, and thereafter every 3 months when using PrEP. And it is preferable also to protect and to screen for hepatitis B before using PrEP. PrEP is not yet implemented in our countries, in our region, and only two countries recommended PrEP as additional approach for combination HIV prevention. And the combination HIV prevention means HIV testing, means also condom use, harm reduction, post-exposure prophylaxis, PMTCT, and others. And now WHO recommend oral PrEP containing tenofovir as additional prevention choice for people at substantial risk of HIV infection. And people who at substantial risk means key population, especially men who have sex with men or female sex workers. And as I said, unfortunately, in our region, only 1 or 2 countries recommended the PrEP and used the PrEP as additional tools of HIV prevention. And some countries also recommended the PrEP for serodiscordant couples, but serodiscordant couples just for the partners of people living with HIV. And some other countries drafted PrEP as a recommendation, but don't use it in their practice. So PrEP is very effective, but unfortunately is not used yet in our region.
So what do you think are the barriers for having PrEP in our region? I think from my perspective, I think that we have cultural barriers, as I have said in the first question. Also, we may have some barriers economic, the price of having the TDF emtricitabine combination, it is not always affordable for the patients or for the healthcare systems that are supporting them or the health insurance. Also, I think we may have some ideas about the possibility of the PrEP to be facilitating the transmission of other sexually transmitted diseases. So, what do you think about these barriers, Dr. Chakroun?
I think we can implement easily PrEP in our region. PrEP is not very costly. We have tenofovir 3TC or tenofovir antricitabine as generic at a very low price. PrEP is very effective, especially for key population. And but we have to pay attention to resistance in PrEP. We have to pay attention to testing, HIV testing, and we have routinely testing every 3 months to avoid for people who are in seroconversion period to have PrEP, and in this period the risk of resistance is very high. So we encourage PrEP, but we encourage very implemented and formal PrEP, because some people in many countries use the PrEP as a non-formal PrEP. So they don't know their status and they use the PrEP. They may be in primary acute infection and they may develop resistance.
Yeah.
So PrEP is not very costly, it's very effective approach. We can implement it in our region. And PrEP may reduce significantly the new infection. So it will be a very important tool to reduce the new HIV infection in our region. And it will be a very strategic and high impact intervention.
But if we have some concerns about the possibility of facilitating the transmission of other sexually transmitted diseases, you don't think so?
No, we don't think so, because many studies don't show that PrEP may change the behavior of people.
Yeah.
So
I'm confirming about. I'm sorry, Shakrun. I was confirming about what you have said, that the IBERGAY and the PROUD and DISCOVER study, all of them didn't confirm any increased risk of sexually transmitted diseases with the PrEP. Yeah.
But what I advise for our region to use the PrEP plus condom, because PrEP will prevent against HIV and condom will prevent against other STI.
Yeah.
But in European countries, they recommend the PrEP without condom.
Yeah.
When we use PrEP without condom, people may be exposed to have some STI as herpes simplex infection, gonorrhea, syphilis, and others.
Yeah, that's right.
Dr. Ahmed, you allow me for a short comment, please?
Sure, Dr. Muhammad.
I agree with Dr. Shakur. It can be given and implemented in our society for special cases. For example, the discordant couple, especially, in our society, there is a lot about gender inequality and the partner-based violence. Sometimes a negative wife cannot resist to do whatever asked by husband, and she knows that he is doing a risky behavior outside. She knows that he has a multiple partner or injecting drug. So in this case, you cannot rely only on you equals you. Maybe he is not adherent to his treatment. So PrEP is something saving her from acquiring infection. And also, sometimes they need to have kids, and he is rushing towards this before complete viral suppression. In this case also, you protect the negative wife by giving her a PrEP. It has its indication still in our society. Not all the time you encourage the bad behavior or the high-risk group. Thank you.
Thank you very much. Thank you very much for this comment. It's a very important point. PrEP should target especially key population, but in our region we can use also PrEP for serodiscordant couple, because when people start the treatment, they need about 6 months to achieve viral suppression, and during this period, the people living with HIV may transmit HIV to the partner. So during this 6 months, the negative partner may take PrEP during 6 months until achieving viral suppression for the positive partner. So this is what we say, PrEP as bridge to U equal U, because when we achieve viral suppression, the people will not transmit sexually HIV. Thank you very much for this comment.
Okay, Dr. Mohammed. So also regarding the PrEP, especially for our situation in Egypt, we don't have the still we don't have the generic TDF emtricitabine available, but we have the generics for the tenofovir and lamivudine in very affordable price. And I think we don't have a lot of data about the possibility for the usage of the TDF plus lamivudine for the PrEP. I think we have some basic data about the interchangeability between the emtricitabine and lamivudine. but especially for the women and the concentration of the lamivudine and the vaginal tissue and the rectal tissue and the men having sex with men, do you think, Dr. Muhammad, can we make use of the TDF plus lamivudine for the PrEP programs in our region? It will be more affordable and more available. And I think there is a lot of countries in Africa now are adopting the TDF 3TC policy for PrEP. What's your insights about this?
Yes, I think because the 3TC and FTC are interchangeable drug, and on pharmacokinetic, pharmacodynamic, 3TC and FTC are same, slightly the same, and we can use TDF 3TC for PrEP. And in some countries they use it only TDF for PrEP. Yeah. So it's better. I don't encourage to use only TDF, but I can encourage Egypt to use TDF 3TC for PrEP.
Yeah.
This is possible.
So on the other hand, do you think that PrEP has a role for the people who are injecting drugs?
No, for people injecting drug, if they have a sexual behavior or risky behavior, sexual risky behavior, yes. But the PrEP don't prevent transmission through blood.
Yeah.
So if we prescribe a PrEP for drug users, because they may have some risky sexual behavior, yes, but sir, PrEP should target MSM and female sex workers.
Yeah. So also now we are receiving some of reports talking about the usage of the concept of the PrEP for other sexually transmitted illnesses, like the usage of the doxycycline for the prevention of syphilis. What do you think about this idea, Dr. Muhammad? We don't have complete data about this, but I have read more than one article talking about the possibility of using the doxycycline as a PrEP or for prevention of syphilis in the same key population.
I think we can use doxycycline and PrEP. There is no problem, and I don't know there is a major drug-on-drug interaction between doxycycline and tenofovir or lamivudine.
But I'm talking about the risk of resistance, antibiotic resistance for this issue.
I think it is the same. With or without a PrEP, the risk of resistance is the same. But yeah, I prefer using PrEP plus condom than using PrEP plus doxycycline.
Yeah, and to be in a formal way, as you have said, that to be to allow for the person who is using the PrEP to know how to use it perfectly and to how to be screened regularly and routinely to avoid any possible problems or interactions.
Yes, they should be screened for STI, but it will be costly. I think when we use the PrEP, we have to be tested every 3 months for HIV. If he's a key population, every year for hepatitis B, hepatitis C, and for STI, it will be clinically assessment, just clinical assessment, because if you use the PCR or other lab tests, it would be very, very costly.
And for the long-acting injectable, do you think, Dr. Muhammad, it will make a change? I think some new reports are talking about the having 1 monthly or 1 weekly injection. It makes people more compliant on the preventive or even the treatment using the antiretroviral therapy. So do you think it will make a major change in the adherence of the people who are should use PrEP to be more compliant on it?
Sure, because the efficacy of PrEP is related to the adherence, and using long-acting injectable will improve and increase adherence of people, and will be the future option of PrEP. Sure, but yeah, it will be a costly option also for our region. This is we have to
make balance,
yes, to make a balance between the cost and the efficacy.
or we have to rush MSD now to make their medication available in the long-acting to be off patent to to allow us to have more generics of these medications.
I think we started in some countries to use bictegravir injectable long-acting bictegravir.
Yeah.
It's used, and also vaginal ring dapivirine also started to be used.
Yeah, this is very good news. So the second issue that I was always talking to you about it is the dual therapy. And now we have a growing evidence about the role of the dual therapy for the management of people living with HIV. I think on the top of this evidence is the Gemini 1 and Gemini 2 studies for the initial treatment, and the SWORD 1 and 2 studies for the maintaining the viral load suppression. And I think some of the guidelines in Europe and USA are now adopting the dual therapy as one of the preferred lines of treatment for the people who are living with HIV. But I think for the WHO and for our region, we still don't have such recommendations in our guidelines. I think the national guidelines in Egypt and in Tunisia and a lot of the countries in the region are not adopting the dual therapy. So what do you think about this, and how can we make use of the dual therapy as an option for our patients?
Thank you very much, and I know that you are for the dual therapy,
Yeah.
Dr. Ahmed, but I think our region is not prepared for this, and it will be maybe a future option of treatment for people stable on antiretroviral therapy. People stable on antiretroviral therapy means people are on ERT and are virally suppression since several years. There are now, as you mentioned in this slide, more evidence on the efficacy of two drugs antiretroviral regimens as the simplification option for people with suppressed viral load on three drug regimens. But for WHO, there are no yet meta-analysis on this topic, and WHO has not elaborated recommendation on this way. So WHO is waiting more data on this to make meta-analysis and to assess the efficacy of the dual therapy and to evaluate also the evidence of the efficacy of this therapy. But we have one question that WHO don't find yet data to answer. When we use, for example, the most used dual therapy are dolutegravir plus lamivudine, or atazanavir plus lamivudine, or darunavir plus lamivudine. And as you know, the mutation M184V is the most common mutation related to 3TC and lamivudine. And when we use dolutegravir, darunavir, or atazanavir plus 3TC, about 80% of people are having this mutation. So we will use dolutegravir on monotherapy, or atazanavir on monotherapy, or darunavir on monotherapy. Sure, darunavir is boosted with ritonavir, is similar than dual therapy, but we don't know how dolutegravir will work when in presence of this mutation. So we will use alone dolutegravir, and we don't have answer to this question. No, we don't have. So this is why WHO doesn't make a recommendation on this, and we are waiting more data on mutation, on how dolutegravir will work alone, and about more randomized trial to make a decision.
Yeah. What makes me always have passion for the second line, for the dual therapy? Let me share with you, Professor, one of the cases that have been following in one of the clinics related to Qasr Al Aini fighting HIV fighting group. We had a patient, he was diagnosed with HIV and was receiving the 2DF FTC plus efavirenz since long time, and he was experiencing worsening of his kidney functions. And still we don't have the TAF available for these patients. Also, he was not able to receive the abacavir because he had some cardiac troubles, and he was totally negative for the hepatitis B assessment. He had hepatitis B surface antigen negative, core total antibody negative, and also hepatitis B viremia was undetectable. So, now usage of the dolutegravir plus lamivudine may be the best option for such patients. So, do you think can we customize like special recommendations for special situations like these situations that we might face?
What cardiac condition she has?
He had ischemic heart
or
disease.
He
has ischemic heart disease, and stenting and BCI and stenting.
We are not sure that abacavir may increase the cardiac risk.
Yeah.
So one study showed that it is, but this study are not confirmed with other data. So in this case, we can use abacavir.
Yeah.
And we can use combination based on abacavir. But here also we can use dolutegravir 3TC and we can add darunavir. So it will be as third line combination. DTG, 3TC plus darunavir boosted with ritonavir. It will be best
better than dual therapy.
Than dual therapy, yes.
Yeah, okay.
Dr. Ahmed, may I add a short comment, please?
Sure, Dr. Mohammed.
Yeah, I agree with Dr. Shakrun. It is not suitable to our societies. It requires a lot of conditions to apply the dual therapy. One of them is strict adherence. The second thing is that patient is having viral suppression since enough time. Sometimes they said 1 year at least or 6 months. Another condition is that no history of resistance. And as you know, we do not have resistance test in our country. In addition to this, complete sure that he has no hepatitis B infection. And because if we take one of the three based regime, then we liable him to have a flare. The benefit of the triple therapy is you have two drugs with dual activity against HIV and HPV. All these conditions is difficult. In addition, they put also a condition in Gemini 1 and Gemini 2 that a good basal viremia and a moderate CD4 count. Also, our patients, they come late while CD4 is very low and viremia is very high. All these conditions to tailor the model suitable for dual therapy is not enough. In addition, in most of the countries that applied the dual therapy, they have it in a single tablet regime. It means that both drugs are in one tablet, which we also don't have. We will ask the patient to take two different tablets, and we cannot agree that he will take it in a regular way. He may miss one of them, then he will be left with a monotherapy. So it is very risky for the time being. I agree with Dr. Shakur.
Thank you very much for this comment, and I would like to add also that in our region, the viral suppression rate is 32%, only 32%. The cascade of care in our region, the 90-90-90, is 52% for people knowing their status, 38% for people on ERT, and only 32 are virally suppressed. So I think in our countries, the priority is to focus on putting treatment patient on treatment, to focus on HIV testing, to link it to care, to start as soon as possible and rapidly antiretroviral therapy and to improve our viral load monitoring. This is our priority in the region.
Yeah, that's right. I am totally agree. So I'm now coming to the end of the points of discussion that I have prepared under the supervision of my professor, Professor Maysat, and I'm inviting any of our professors on board if you need to raise any points for discussion with Professor Chakroun. So if we don't have any more points of discussion or any more questions, so we are coming to the end of our session and our meeting today. I'd like to thank all of my dearest professors for their availability and their time and very rich discussions that we have had today with our participants. And I think Dr. Amgad will give a final comment about the meeting today.
So I'd like to thank you all for this very fruitful and nice participation and this very informative session, and hoping to see you, inshallah, soon in other scientific events. Thank you very much for all, and see you, inshallah, soon.
Thank you. Thank you. Bye.
Welcome. Bye. شكرا دكتورة ميساء.
شكرا دكتور امجد لحضرتك، احنا اللي شاكرين لحضراتكم.
بشكر الدكتورة هبة طبعا على
دكتورة هبة زي حضرتك.
اهلا يا دكتورة ميساء، زي حضرتك.
الله يسلمك.
شكرا جزيلا جميعا.
شكرا.